I'm Paula James from Queen's University, and my red hot topic for CODEROUGE 2021 is an update on the Vwd Guidelines. The goal of this project was to produce clinical recommendations to diagnose and manage VWD, and we took the perspective of a high resource setting, but there are ongoing efforts to adapt to other settings. This was a collaborative project with ASH as the leading organization, but we had partnerships from ISTH, NHF, and WFH. There were clinical and patient experts on both panels with representation from hematology, pediatrics, gynecology, and basic science. The patient experts were critical to the process and were full voting members. All of the panelists were nominated by partner organizations, and there was geographic diversity with representation from North and South America, as well as Europe and Australia. We followed the grade methodology, which requires the identification of PICO questions, with PICO standing for patient, intervention, comparator, and outcome. There was no industry funding or involvement in the project whatsoever, and panelists had to avoid or manage conflicts during their time on the project. The topics that we chose were prioritized by an international survey of over 600 respondents. For diagnosis, we made recommendations on bleeding assessment tools, VWF assays, and diagnostic cutoffs, and what to do with patients who have VWF levels that normalize with age. For management, there are recommendations on prophylaxis, DDAVP trials, antiplatelet therapy, major and minor surgery, the management of heavy menstrual bleeding, and neuroaxial anesthesia and how to prevent postpartum hemorrhage. So, in ridiculous speed, here's a summary of the diagnosis recommendations. Bleeding assessment tools are effective screening tools, especially in adult women in the primary care setting. They are also useful in the tertiary care setting to document the severity of bleeding. The VWF GP1BM is a better assay than the ristocetin cofactor assay. Don't dismiss patients with VWF levels that have normalized with age. They might still bleed. Diagnose type 1 VWD in anyone with VWF levels less than 30%, and in those with levels between 30 and 50 and abnormal bleeding. Use a DDAVP trial with a 4-hour post-infusion time point to identify type 1C rather than the VWF propeptide assay. Use a VWF activity to antigen ratio cutoff of less than 0.7 to identify type 2 VWD. Use either VWF multimers or the collagen binding assay to further investigate type 2 VWD. And genetic testing is helpful for both 2B and 2N VWD, but you may also want to do the VWF factor VIII binding assay for type 2N. Only 2 of these recommendations are strong. The rest are conditional because of low quality evidence. For management, we recommend that VWD patients with severe and frequent bleeds should be on prophylaxis. Do a DDAVP trial, especially on patients with VWF levels less than 30%. For patients with cardiovascular disease, give antiplatelet agents. For major surgery, target both the VWF and factor VIII levels of greater than 30% for at least 3 days and use both assays to monitor. Use tranexamic acid for minor surgery with or without desmopressin or VWF concentrate, depending on the factor levels and bleeding phenotype of the patient. Combined hormonal contraceptives, the levonorgestrel releasing IUD and tranexamic acid are better than DDAVP to treat heavy menstrual bleeding. Use tranexamic acid alone if the patient wants to conceive. Aim for VWF activity levels between 50 and 150% for neuroaxial anesthesia, and use tranexamic acid to prevent postpartum hemorrhage. There are no strong management recommendations because of low quality evidence. And so it is imperative that we generate higher quality evidence for the management of our VWD patients. If you're interested in the actual detail behind these recommendations, as well as the rationale and the evidence, please have a look at the publications that can be found in Blood Advances from the January 2021 edition. I want to acknowledge all of the people who were involved in this project, especially my friend and colleague, Dr. Nathan Cannell, who helped with the slides today. Thank you for your attention.